It's an exciting time in metastatic bladder cancer in the sense that, over the past several years we've had the introduction of 5 new FDA-approved immunotherapies, and we're trying to solve how to integrate those. Where do we use them? At what sequence do we use them along with chemotherapy, which has been our standard tools for many years? And I think it's really changed even over the past year in the sense that when the immunotherapies first came to market, clearly they were approved in the platinum refractory setting, and every patient was essentially getting those therapies. But then there was also the interest in using them in the frontline setting, and I'd say a year ago I was using them a lot more in the frontline setting, but it's really changed dramatically just in the last couple of months with the FDA announcements that in the frontline setting that we really are restricted now in our use of immunotherapies if the patient hasn't received platinum yet. Certainly cisplatin-based therapy is the gold standard still in that frontline setting. So if your patient's cisplatin eligible, you're going to be offering them a cisplatin-based combination. Those patients who traditionally then are cisplatin ineligible, those are the patients a year ago we were really pushing a lot more of the immunotherapy with the FDA announcement. Now it seems that those patients should be getting gemcitabine carboplatin rather than immunotherapy, monotherapy, unless we know that that patient's PD-L1 positive. So now we're doing PD-L1 testing in that frontline setting to try to perhaps identify those patients where we still might use immunotherapy in that setting. And then of course there's that small segment of patients that they're really not chemotherapy eligible at all, not fit for any type of chemotherapy, even carboplatin-based therapy. And those patients then, according to the new FDA guidance, would be eligible to receive immunotherapy as opposed to no treatment at all.